Welcome to section 15 of the online anatomy review series. This is going to be the section where we discuss the vessels and vascular related issues of the upper limb. We'll start by looking at the axillary space and some of the brachial plexus as it courses through the axillary sheath. Right now we're going to focus in on the vascular structures around it. In this view, you can see that there's an anterior wall that's composed of the pectoralis major. There's going to be a posterior wall which is composed of the subscapularis, teres major, and latissimus dorsi muscles. And then you can look at the medial wall on the small inset in the right of the picture, which would show a serratus anterior with its finger-like digitations coming around to the ribs. And then finally a lateral wall, which would be the humerus itself. In many places it's described as a pyramid projecting up with its apex towards the neck and its base towards the floor. The floor of the axilla itself is the axillary fascia, which is a fairly dense and tough sheath of tissue that will come across and contain the space across the armpit. Now, as we look at the contents of the axillary sheath, it's really a neurovascular bundle within a sleeve of connective tissue, and it contains the portions of the brachial plexus as well as the vessels of the axilla. In fact, the axillary artery is used to name the various cords of the brachial plexus. So in this view you can see above the artery there would be the lateral cord, below the artery would be the medial cord, and behind the artery would be the posterior cord. And you can even see the pectoral branches coming into the pectoralis minor and pectoralis major coming through the axillary sheath. The sheath is going to blend down into the brachial sheath as a continuation of it, and it's going to give off brachial fascial compartments that can happen if it gets into a blood flowing into that space. So if we look at the compartments of this axillary sheath, it extends from the clavicle to the elbow. It has the terminal branches of the brachial plexus and the axillary vessels which become brachial vessels, and it's formed by the medial intermuscular septum. The contents in here will be the brachial plexus, axillary artery, axillary vein, and the axillary lymphatics. As far as pathophysiology, there's several lesions that are possible within the compartments which can cause hematomas. There can be aneurysms, or there can be space-occupying masses. There can be pain and paresthesias because of the cutaneous distributions of these nerves, weaknesses in distribution of the affected areas, and most commonly the median nerve will be affected. Other nerves in the compartment will include the musculocutaneous, the axillary, and the radial and ulnar as they distribute down through the limb. We'll talk more specifically about these and their involvements with the different compartments they're innervating a little bit later. Let's look at a vascular question. A pitcher for a baseball team is diagnosed with traumatic axillary aneurysm. Surgically, it's possible to successfully tie off the first part of the axillary artery because of which vessels that would provide distal segment vascularization. The suprascapular and circumflex scapular vessels will anastomose, and the logic behind this choice is the same as what we saw in the lower limb, where you've got the portion before the blockage that needs to get around to the portion after the blockage. Now, in looking at this, we'll learn a little bit later that it's the anastomoses around the shoulder where the suprascapular vessel will be coming from the subclavian artery, and the circumflex scapular will be coming off the distal components of the axillary artery, and they'll anastomose around the shoulder, giving an alternative blood supply pathway for any blockages that would occur within the axilla itself. As a summary of the upper limb vessels, we have the subclavian vessel, which ends at the lateral edge of the first rib and becomes the axillary. It gives off a vertebral that ascends the neck, an internal thoracic that descends the anterior thoracic wall, a thyrocervical trunk that will supply the lateral shoulder and the thyroid gland, and oftentimes a suprascapular that comes off independently, or it may come off the thyrocervical trunk. The axillary, which ends at the inferior edge of teres major, has a superior thoracic, a thoracoacromial trunk, which has a deltoid and pectoral, acromial and clavicular, which is two muscular and two bony branches, the lateral thoracic, which ascends the lateral side of the thoracic wall on top of serratus anterior, the suprascapular, which will descend off the lateral component towards the subscapularis muscle and then give off a circumflex scapular that will go around to the posterior aspect of the scapula, and a thoracodorsal, which will continue to the latissimus dorsi and oftentimes give assistance to the lateral thoracic. Then we have two that head laterally. One, the anterior humeral circumflex, and two, the larger of them usually, is the posterior humeral circumflex, which go around the humerus towards the lateral aspect. Once you get past the axillary artery, it branches into a brachial and gives off a deep brachial and several collateral branches above the elbow for the anastomosis of the elbow. Then once the brachial crosses the elbow anteriorly, it will branch into a radial and an ulnar. The radial and ulnar will both give off recurrent branches to assist the collaterals in the circulation around the elbow. The radial will then descend on the superficial lateral aspect and then cross into the dorsum of the hand by going through the snuff box and becoming the deep palmar arch. Just before it becomes deep palmar arch, it gives a branch to the thumb, the princeps pollicis, which is the vessel that you feel when you take a pulse with your thumb, and the radialis indicis branch. The ulnar, on the other hand, branches up in the deeper portions of the proximal forearm and gives off a common interosseous, which then typically will feed the anterior and posterior interosseous branches, descending down on the deep posterior and the deep anterior surfaces of the flexor and extensor forearm. Then the ulnar will cross into the wrist in the ulnar tunnel along with the nerve and become the superficial palmar arch, which will then give off common palmar digitals and proper palmar digitals to each of the digits. Let's take a quick look at these branches of the axillary artery and follow them down. We have part 1, part 2, and part 3 of the axillary artery. Part 1 is the superior thoracic, a descending branch. Part 2 is the thoracoacromial, which actually is a branch that ascends or goes up. And then we have the lateral thoracic vessel and the part 3 components, which will be composed of the subscapular, the anterior and posterior humeral circumflex branches, and off of the subscapular there'll be a circumflex scapular, and finally a thoracodorsal, which is headed towards latissimus dorsi. Each of these three parts is separated by the pectoralis minor muscle, which is, if you're proximal to that portion, you're going to be part 1. If you're behind it, you're going to be part 2. And if you're lateral to it, you'll be part 3. Here you can see the shoulder anastomosis that we talked about earlier. There's going to be branches from the dorsal scapular artery and the suprascapular artery, which are both from the subclavian vessels, and they're going to anastomose with the circumflex scapular and some of the ascending branches of the posterior humeral circumflex, which will come around and complete the anastomosis off of the axillary branches. Once we get into the arm, it's going to ascend into the elbow itself from the brachial artery, and it's going to give off a deep brachial in the superior and posterior aspects of the brachum. And finally, once it crosses the elbow anteriorly, it's going to be breaking into the radial and ulnar. Remember, collateral branches are above the elbow for the anastomosis of the elbow, and recurrent branches are below the elbow. Off of the ulnar, you can see here the common interosseous artery, which will then usually divide into an anterior and posterior interosseous artery. Let's look at a question. A young woman accidentally pushed her hand through a glass door and bled profusely from a superficial laceration on the anterior aspect of her wrist. She had sensory loss over the palmar aspect of the medial 1½ fingers. She was unable to grip a piece of paper between her left ring and middle fingers, but all the long flexors were intact. Which artery and nerve were cut in the accident? This seems like a fairly involved question with a lot of things to think through. All that you really need to focus in on at first is that she's on the anterior aspect of her left wrist, and she has 1½ fingers affected, which means she's on the ulnar side. And once you determine that, you have a fairly hard time ruling out something that has ulnar in it. And the other principle that you need to bring to a question like this is the basics. And one of the basic foundations that we know is that arteries tend to run with nerves of the same name. So if you're looking at option A, you have radial artery and radial nerve, which are running together, but they're on the wrong side. If you're looking at ulnar artery and median nerve, well, those are two different things that are running together, so that certainly would be less likely, even if you didn't know the detail. The answer here is going to be the ulnar artery and the ulnar nerve, because they're on the right side and they're running together. If you look at the other option in D, radial artery and ulnar nerve, again, they're not on the same side as one another. And then if you look at the anterior interosseous artery and radial nerve, one is in the flexor compartment and the radial nerve is in the extensor compartment. Again, they don't run together. So it would be very difficult to have those cut in a single incident unless they were pretty incredible incidents, so you'd need a magic bullet. Now let's look at the distal blood supply as we get into the hand. Here you can see the branches of the ulnar artery as they cross over superficially to the palmar arch and make the superficial palmar arch, then distribute into the common palmar digital and proper palmar digitals. Notice how these proper digitals distribute on the medial and lateral sides of the fingers, which stops them from being compressed when you hold on to something tightly. Notice that your hands actually go numb when you put on tight gloves, which compresses the lateral sides, as opposed to holding on to something for a really long time because of this architecture. Now this vessel is going to have significant connection with the artery on the opposite side, which will be the radial artery. The radial artery stays in the flexor forearm until the very distal components, after which it will go deep through the snuff box and dive in through the first dorsal interosseous at the base of the first metacarpal to become the deep palmar arch, except it won't do this until after it gives off its princeps pollicis to the thumb and its radialis indicis branch to the lateral side of the index finger. Now these vessels have an anastomosis between the two. If they don't, the arteries can't be harvested and used for a bypass surgery, but if they do have a good anastomosis, which can be tested through the Allen's test, where you block both vessels off, squeeze the blood out of the hand and release one, and then do it again and release the other to see whether or not one vessel alone can fill that entire hand with blood. Let's look briefly at the veins of the upper limb, since so many clinical things will happen where you'll be taking blood out of or putting medications and drugs into the venous architecture of the forearm. On the lateral side you have the cephalic system of veins of the forearm, and on the medial side you have the basilic system of veins. And they have many variations. One of the most common is the median cubital, which crosses from the cephalic over to the basilic. In the first image we have actually a median basilic and median cephalic variation of that. On the dorsal aspect of the wrist, this will be another dorsal venous arch where you can access and sometimes do a cut down or put fluids into or out of that vessel by the dorsal venous arch. The median cubital or median basilic are going to be veins that cross over top of the cubital fossa. And the cubital fossa is the area at the elbow which has as a protective roof the biceps aponeurosis, which is heading medially around the muscles of the forearm flexor. Deep to this, we have the contents of the cubital fossa, which I use the mnemonic LATTAN to remember. From lateral to medial, we have the lateral antebrachial cutaneous nerve that's running right near the cephalic vein. That's the continuation of the musculocutaneous nerve after it's given off its motor branches. And then from lateral to medial, we have the tendon of the bicep. We have the artery, more medial than that, of the brachial artery. And then we have the median nerve, more medial than that. So from lateral to medial, it's tendon, artery, and nerve. Oftentimes, there will be cases that you need to be aware of for this area because there's so much venipuncture going on in this area. That it's not uncommon to have cases where someone will insert a needle into the median cubital vein, go through the aponeurosis, and then tag that median nerve or the brachial artery, causing hematoma in that area. So be weary of those kind of questions and know your anatomy of your cubital fossa for that very reason. Let's try another question. A 52-year-old woman is diagnosed with breast cancer with a tumor located in the lateral inferior quadrant of the left breast. Into which nodes will most of the lymph from the breast initially drain? And the answer is anterior. Because of the prominence of breast cancer, it's not uncommon to get a question that deals with the lymphatics in the axilla, which is where 3/4 of the breast drainage is going to be draining into. We'll talk more about that when we get to thoracic wall, but it's a good time at this point to talk about the fact that these lymph nodes that are draining the upper limb are going to be tied together with the thoracic wall lymph nodes. They're basically named by position. So the anterior pectoral nodes can actually be called pectorals, and the posterior can be called the subscapular or scapular nodes. Then we have the central, and then on either side of the centrals we have laterals, which would be more distal, and the apicals, which would be up the chain further, near the clavicle. The anterior nodes will be the sentinel nodes in most of the drainage of the breast, because 3/4 of that breast will drain there. The parasternals will drain the more medial components of the breast. Here you can see a couple more pictures of the axillary nodes as they're located up in the axilla. And you can see these superficial cubital nodes, which will drain from the basilic venous system or the median cubital from the cephalic system into the superficial components before diving deep into the brachial vein. So you can see the lymphatics of the upper limb will be a set of chains from superficial to deep. Again, once they go deep, they stay deep. The nodes tend to cluster with lots of variation, and they're typically named by location. If you know the drainage pathway of the veins, whether superficial or deep, you essentially can follow that same pathway and even the same naming of the nodes as they travel along the veins. Once you get into the core of the body, there'll be some lymph nodes that travel with the major vessel, the aorta, but for the most part in the periphery they travel with the venous system. So here's the named nodes of the axilla. And they have very low pressure. One of the major side effects of having staged breast cancer is that this chain of nodes will be taken out. and hopefully they see that the cancer has not progressed past the apical nodes, because there's only one more set of supraclavicular nodes before they drain back into the venous system and have the chance to metastasize throughout the body. So once they pull out this set of nodes, edema of the limb can be a significant problem and can sometimes lead to compartment syndromes for people that have too much lymphedema. And let's talk a little bit about venous problems of the upper limb. You can have air embolisms, which are oftentimes associated with the axillary vein, which can bleed so fast and so quickly that it allows air emboli to pass right into the right side of the heart. And the problem with air embolisms is that the closer you are to the right side of the heart, the less air volume that you need to cause major problems. Since you're so close with this axillary or even the cephalic vein, you can cause an increase in pulmonary artery pressures, which will reduce the venous return to the left atrium, and that reduced venous return will cause reduced flow to the left ventricle, and that will put systemic output in danger, and that will result in potentially a systemic collapse and death. So, of course, air emboli are something to be avoided, but you may see them because they are procedural risks associated with opening up a vessel and a vein. Effort thromboses. A thrombus can be formed from spontaneous and excessive or unaccustomed movements. For instance, young athletes, and one of the typical examples would be baseball players that often throw super hard to try to throw the pitch. They'll often have excessive forces laid into the vein, and it can cause a thrombus that can break loose and cause all of the regular problems that a thrombus can. Central line catheters and port placements can be done through the axillary vein and through the cephalic vein as well, for administering parenteral fluids and medications to measure the central venous pressure in the right atrium or ventricle. And then finally, venous cut down, where we talked already about the idea that the cephalic vein or the dorsal venous arch can be areas that will be cut down. The axillary aneurysm is something that's similar to the venous thrombus. An aneurysm can be formed because of excessive forces into the arterial wall, which cause it to be thin and weakened. This can compress the trunks of the brachial plexus, or it can eventually break free and cause excessive bleeding. The subclavian steal syndrome is an asymmetry of brachial blood pressures of at least 20 millimeters of mercury, which produces a transient upper extremity and cerebral ischemia. And this is oftentimes associated with compressions of the subclavian vessels so that it doesn't distribute properly. Profunda brachii injuries via the humeral fractures. This can cause excessive bleeding, and it may be injured at the spiral groove, where we talked about the radial nerve also being injured there. Also, with the supracondylar fractures, at risk with the median nerve is the brachial artery. Ulnar arteries more at risk with wrist injuries, and the lacerations that people will often do in attempts to commit suicide. We've discussed already the Allen test for patency of those vessels, so that they can be used for bypass surgery or cabbages. That concludes section 15 on the vasculature of the upper limb. The next section will discuss the nerves of the upper limb, and this will be a key area for understanding the brachial plexus, so it's important that you spend significant amounts of time making sure that the brachial plexus is definitely something you understand.